Welcome to part 10 of our nephrology board review series, the final part. Today we are covering respiratory and mixed acid base disorders. This brings together everything we have learned about acid base physiology and tests your ability to analyze complex cases with multiple disorders. Understanding compensation formulas and the systematic ABG approach is essential for boards. Let's work through 8 KSAP-style questions. A 65-year-old man with severe COPD presents with worsening dyspnea over 3 days. His ABG shows pH of 7.32, PCO2 of 70, bicarbonate of 35. His baseline PCO2 is 55 with bicarbonate of 30. How do you interpret this ABG and what is the expected compensation? Your options are A. Acute respiratory acidosis. Expect bicarbonate to rise 1 milliculent per 10 millimeter rise in PCO2. Option B, chronic respiratory acidosis with acute exacerbation. It's a mixed compensation pattern. C, pure chronic respiratory acidosis. Expect bicarbonate to rise 3.5 per 10 millimeters mercury. Option D, metabolic alkalosis with respiratory compensation. Take a moment to review these choices. So the answer is B. This is chronic respiratory acidosis with an acute exacerbation, basically acute on chronic, and you can see it from the compensation pattern. Let's walk it through quickly. At baseline, this patient was already chronically compensated, PCO2 of 55 with a bicarb of 30. That tells you his kidneys had time to adapt. Now he acutely worsened. The PCO2 jumped from 55 to 70. So that's an increase of 15 millimeters mercury. But the bicarb only went from 30 to 35, so it rose by 5. That bicarbonate rise is too much for a purely acute process, but not enough for full chronic compensation. And that in between pattern is the giveaway for acute on chronic respiratory acidosis. The key ratios to remember are in acute respiratory acidosis, bicarb goes up by about 1 for every 10 rise in PCO2. In chronic respiratory acidosis, bicarb goes up by about 3.5 for every 10 rise in PCO2 because the kidneys have had time to compensate. A quick pearl here, chronic compensation is about 3.5 times stronger than acute, but it takes a few days, roughly around 3 to 5 days, to fully kick in. So, for this patient, since the bicarb sits between the acute and chronic expectations, the best interpretation is acute on chronic respiratory acidosis. Moving on, we have a 28-year-old woman at an altitude of 3,500 meters for 1 week who has an ABG of with pH of 7.46, PCO2 of 28, bicarbonate of 19. She feels well with mild dyspnea on exertion. What is the acid base pattern here, and is the compensation appropriate? Your options are acute respiratory alkalosis. Bicarbonate should drop 2 per 10 millimeters 2 per 10 millimeters mercury for PCO2 decrease. Option B, chronic respiratory alkalosis. Bicarbonate should drop 5 per 10 millimeter drop in PCO2. Option C, mixed respiratory alkalosis and metabolic acidosis. Or option D, primary metabolic acidosis with respiratory compensation. So the answer is B. And this example shows chronic respiratory alkalosis with appropriate compensation. She has been at high altitude for about 1 week, which is important because that gives the kidneys enough time to fully adapt. So this is not an acute process anymore. This is chronic compensation. Let's walk through the numbers. Her PCO2 dropped from normal 40 down to 28, which is a decrease of about 12 millimeters mercury. In chronic respiratory alkalosis, we expect bicarbonate to fall by about 5 per 10 millimeter drop in PCO2. So if we do the math, that's roughly 5 times 1.2, which equals 6 milliequivalent decrease. Starting from a normal bicarbonate of 24, that would bring us down to about 18. Her actual bicarbonate is 19, which fits extremely well with appropriate chronic compensation. Now, here are the key ratios to remember. In acute respiratory alkalosis, bicarbonate drops by about 2 for every 10 drop in PCO2. That's mainly rapid buffering. In chronic respiratory alkalosis, bicarbonate drops by about 5 for every 10 drop in PCO2 because the kidneys actively excrete bicarbonate. Here's an important pearl. Chronic respiratory alkalosis is the only acid base disorder where the pH can actually return close to normal because the kidneys can lower bicarbonate significantly, sometimes even down to lower teens. So, common causes you should always think about include high altitude, pregnancy, liver disease, sepsis, anxiety, and pain, all of which can drive hyperventilation. So, the big takeaway here is acute respiratory alkalosis follows a 2 to 10 rule, chronic follows a 5 to 10 rule, and chronic causes can sometimes normalize the pH completely. Next up, we have a 55-year-old alcoholic who is admitted with vomiting, confusion, and respiratory distress. ABG shows pH of 7.4, PCO2 of 24, bicarbonate of 14, and sodium of 140 with chloride 90 and an ion gap of 36. Serum ketones are positive. Lactate level is 6. So, how many acid base disorders does this patient have? So, one, compensated metabolic acidosis. Two, there is high anion gap metabolic acidosis plus respiratory alkalosis. Option C, three, high anion gap metabolic acidosis plus metabolic alkalosis plus respiratory alkalosis. Or option D, two, high anion gap metabolic acidosis plus metabolic alkalosis. So the answer is C. This patient actually has three acid base disorders happening at the same time: a high anion gap metabolic acidosis, a metabolic alkalosis, and a respiratory alkalosis. And the biggest trap here is the normal pH of 7.4. If pH looks normal, but the bicarb and CO2 are clearly abnormal, that should immediately make you think multiple opposing processes are canceling each other out. So let's break it down quickly. First, the anion gap is 36, which is very high. Compared to a normal anion gap of 12, that's an increase of about 24. So this is definitely a high anion gap metabolic acidosis. In this setting, think of alcoholic ketoacidosis and often lactate contribution too. So second, I check delta delta to see if there is another metabolic process hiding. Delta gap is 24, the bicarbonate is 14, so the bicarb drop from 24 is from a normal of 24 is 10. So the delta delta ratio is 24 divided by 10, which is 2.4. When that ratio is above 2, it means bicarbonate didn't fall as much as it should have, so there is a hidden metabolic alkalosis. Classically, in this situation, it happens from vomiting. Third, I use Winter's formula to see what the lung should be doing if this were a only metabolic acidosis. The expected CO2 is roughly 27, but the actual CO2 is 27, which is lower than expected. So there is also a superimposed respiratory alkalosis, often from sepsis or liver disease in this kind of a patient. So this is the classic alcoholic triad: alcoholic ketoacidosis causing high anion gap acidosis, vomiting causing metabolic alkalosis, and sepsis or liver disease causing respiratory alkalosis. So, the main teaching point here is a normal pH does not mean a normal acid base disorder. When values look wild, but the pH is normal, assume two or even three disorders and use delta delta and Winter's formula to prove it. Next up, we have a patient with diabetic ketoacidosis who has ABG, which shows pH of 7.22, PCO2 of 18, bicarbonate of 37. Using Winter's formula, expected PCO2 equals 1.5 times 7 plus 8 plus minus 2, which equals 16.5 minus 20.5. Uh, yep, 20.5 millimeters mercury. So, what does this analysis reveal about patients' respiratory compensation? A. Appropriate respiratory compensation for metabolic acidosis. B. Superimposed respiratory acidosis, PCO2 higher than expected. C. Superimposed respiratory alkalosis with PCO2 lower than expected. Or D. Cannot determine from this information. Okay. So the answer is A. This example shows appropriate respiratory compensation. The patient's actual PCO2 is 18, and that falls nicely within the expected compensatory range, which is about 16.5 to 20.5. That tells us this is a pure metabolic acidosis, and the lungs are responding to exactly the way they should. To check this, we use Winter's formula, which helps predict how much lungs should lower CO2 in metabolic acidosis. So the formula is expected PCO2 equals 1.5 times the bicarbonate plus 8 plus or minus 2. So here's how to interpret it. If the PCO2 falls within the expected range, it is just metabolic acidosis with appropriate respiratory compensation. If PCO2 is higher than expected, that means there is an additional respiratory acidosis going on. If the PCO2 is lower than expected, that means there is a superimposed respiratory alkalosis. So there's also a quick bedside shortcut. The PCO2 often roughly matches the last two digits of the pH. So if the pH is 7.22, you'd expect PCO2 around 22. In this case, it's 18, which is reasonably close and still consistent with compensation. And here is an important clinical warning. If a patient with metabolic acidosis has a PCO2 that is higher than expected, it may mean the patient is tiring and can no longer compensate adequately. That's a red flag and may signal the need to evaluate airway protection or consider ventilatory support. So, the big takeaway is simple: always apply Winter's formula in metabolic acidosis. It's one of the easiest ways to uncover hidden respiratory problems. In our question number 5, we have a patient with severe metabolic alkalosis who has pH of 7.58. Bicarbonate is 48 and PCO2 is 52. The formula for metabolic alkalosis compensation suggests PCO2 should rise by zero point 0.7 times the change in bicarbonate. What is the physiologic limit of respiratory compensation for metabolic alkalosis? Your options are A. PCO2 cannot rise above 40 millimeters mercury. B. PCO2 rarely exceeds 55 millimeters mercury due to hypoxia drive. C. PCO2 can rise to 80 millimeters mercury with severe alkalosis. Or D. There is no physiologic limit to compensation. So the answer is B. One important concept to remember is that PCO2 usually does not rise above 55 millimeters mercury during compensation for metabolic alkalosis. The reason comes down to physiology. When the body tries to compensate for metabolic alkalosis, it does so by hypoventilating to retain carbon dioxide. But as ventilation slows, oxygen levels start to drop. Once hypoxemia develops, the body's hypoxic drive kicks in and forces breathing to increase again. That creates a natural ceiling and prevents the PCO2 from rising much higher than about 55. There are a few key compensation limits that are worth memorizing. So, for metabolic acidosis, the PCO2 generally cannot drop below about 10 millimeters mercury because the respiratory muscles simply can't hyperventilate any further. For metabolic alkalosis, the PCO2 rarely rises above about 55 millimeters mercury because the hypoxia prevents further hypoventilation. For chronic respiratory alkalosis, the bicarbonate level is usually cannot fall below about 12 milliequivalents per liter, which represents the kidney's limit for bicarbonate excretion. So here's an important clinical pearl. If you see a patient with metabolic alkalosis and the PCO2 is higher than 55, you should strongly suspect an additional respiratory acidosis. A classic example would be a patient with COPD who is also losing gastric acid from vomiting. If you want to estimate expected compensation in metabolic alkalosis, you can use this formula. Expected PCO2 equals zero point 0.7 times the bicarbonate plus 21 plus minus 2. So the big takeaway is to remember these physiologic limits. Metabolic alkalosis usually caps PCO2 around 55. Metabolic acidosis rarely allows PCO2 to drop below 10. And chronic respiratory alkalosis usually bottoms out bicarbonate around 12. So knowing these limits help you quickly recognize when another acid-base disorder is hiding in plain sight. Next up, we have a 70-year-old man with pneumonia and sepsis. His ABG shows pH of 7.48, PCO2 of 25, and bicarbonate of 18. Lactate is 1.5, which is normal. Anion gap is 14. What is the primary acid-base disorder and why is this common in early sepsis? So options are A. Metabolic acidosis with respiratory compensation. B. Respiratory alkalosis due to cytokine stimulation of respiratory center. C. Mixed metabolic and respiratory alkalosis. Or D. Respiratory acidosis from pneumonia. So the answer is B. This pattern represents respiratory alkalosis driven by cytokine stimulation of the respiratory center, and it's an important clinical clue. So, one key pearl to remember is that early sepsis often presents with primary respiratory alkalosis. Inflammatory cytokines directly stimulate the brain's respiratory center, which causes hyperventilation. And this can happen even before lactate rises. So, in this case, the bicarbonate of 18 is actually compensation for respiratory alkalosis. It does not automatically mean there is a primary metabolic acidosis going on. A helpful way to think about sepsis is in stages. So, in early sepsis, respiratory alkalosis is common because cytokines drive hyperventilation. As sepsis progresses into the intermediate stage, you may start to see mixed acid base patterns as lactate levels begin to rise. And in late sepsis, patients often develop a clear high anion gap metabolic acidosis from lactic acidosis. So here's an important board pearl. If you see respiratory alkalosis with a normal lactate level in a very ill patient, you should strongly consider early sepsis or liver failure. Other conditions that can cause respiratory alkalosis include pregnancy, high altitude exposure, anxiety, pain, and liver disease. So, the main takeaway is this: early sepsis often causes respiratory alkalosis due to cytokine driven hyperventilation, while late sepsis typically leads to lactic acidosis. Next up, we have a COPD patient on chronic ventilatory support with baseline PCO2 of 60 and bicarbonate of 32. He's aggressively ventilated and dropping PCO2 to 40 within hours. New ABG shows pH of 7.52 and PCO2 of 40 with bicarbonate of 32. What has happened here and why does the alkalosis still persist? Your options are A. Respiratory alkalosis from overventilation, B. Post hypercapnic metabolic alkalosis, kidneys retain bicarbonate slowly, C. Contraction alkalosis from diuretics, or D. Primary metabolic alkalosis unrelated to ventilation. So the answer is B. This shows post hypercapnic metabolic alkalosis, which happens because the kidneys remove bicarbonate very slowly. So here's the physiology behind it. In chronic hypercapnia, the kidneys adapt over time by retaining bicarbonate to buffer the elevated carbon dioxide levels. That compensation usually develops over days to weeks. Now, if the carbon dioxide level is rapidly corrected, usually after aggressive ventilation, the bicarbonate level doesn't immediately fall. The kidneys simply can't excrete bicarbonate that quickly. So the bicarbonate remains elevated and that produces metabolic alkalosis. If you walk through the numbers, it makes sense. In the chronic state, the patient might have a PCO2 of 60 with a bicarbonate of 32, which represents appropriate long term compensation. Then ventilation rapidly lowers the PCO2 back to around 40, but the bicarbonate is still sitting at 32. That imbalance drives the pH up, leading to alkalemia. Here's an important clinical pearl. When managing patients with chronic hypercapnia, avoid correcting PCO2 too quickly. The goal is to lower CO2 gradually, which gives kidneys time to excrete the excess bicarbonate and prevents overshooting into alkalosis. Management usually focuses on three things. First, gradual adjustment of ventilator settings. Second, replacing chloride, often with normal saline or potassium chloride, because this type of alkalosis is typically chloride responsive. And third, in selected cases, medications like acetazolamide can help promote bicarbonate excretion. So the big takeaway is this: rapid correction of hypercapnia can trigger post hypercapnic metabolic alkalosis, and it's usually treatable with chloride replacement and careful ventilator management. So, our last question: you have a critically ill patient who has pH of 7.25, PCO2 of 30, bicarbonate of 13, sodium of 142, chloride 100, and an ion gap of 29. You want to fully characterize the acid base status. What is the correct sequence of steps for systematic ABG analysis? Your options are A. First check pH, then identify primary disorder, then calculate an ion gap, then check for compensation, then check delta delta. Option B, calculate an ion gap first, then pH, then compensation. Option C, check compensation first, then pH, then an ion gap. Option D, check delta delta first and then determine primary disorder. So the answer is A. Here's a simple 5-step approach to ABG interpretation that works extremely well both for exams and real clinical practice. First, always start with pH. Decide whether the patient has acidemia or alkalemia. If the pH is below 7.35, it's acidemia. If it's above 7.45, it is alkalemia. Second, identify the primary disorder. Ask yourself whether the problem is metabolic or respiratory. So, the easiest way to do this is to look at which value, PCO2 or bicarbonate, is moving in a direction that explains the pH. Third, always calculate the anion gap, even if the question doesn't specifically ask for it. Missing a high anion gap can completely change your interpretation and make you miss mixed disorders. Fourth, check whether the compensation is appropriate. You can use Winter's formula when evaluating metabolic acidosis and use the metabolic alkalosis compensation rule when there is metabolic alkalosis and apply respiratory compensation rules when the primary disorder is respiratory. Fifth, if there is a high anion gap metabolic acidosis, calculate delta delta ratio to look for additional hidden metabolic disorders. Now, if you apply this stepwise approach, it becomes much easier to avoid missing mixed acid base disorders. So let's apply this to this patient. A pH of 7.25 indicates acidemia. Low bicarbonate indicates metabolic acidosis is primary. An ion gap of 29 confirms high anion gap metabolic acidosis. Winter's formula gives expected PCO2 of 27.5 plus minus 2. Actual is 30, so this is appropriate. Delta delta ratio of 17 divided by 11 equals 1.5. That's between 1 and 2, indicating pure high anion gap metabolic acidosis. So the big takeaway is to stay systematic, start with pH, then identify primary disorder, and then calculate an ion gap, then check compensation, and finally calculate delta delta when a high anion gap metabolic acidosis is present. Following this sequence helps you consistently arrive at the correct diagnosis and prevents missing mixed complex disorders. All right, here's a simple master approach you can use for almost every acid based question. So, first you start with pH, decide if the patient is acidemic or alkalemic. That immediately tells you which direction you're heading. Next, figure out primary disorder. Decide whether the main problem is metabolic or respiratory by looking at which value explains the pH change. After that, always calculate an ion gap. Even if it's not asked, this step is critical because hidden high anion gap disorders are one of the most common reasons people miss mixed acid base problems. Once you've done that, check whether the body is compensating appropriately using the expected compensation formulas. If the compensation doesn't match what you expect, that usually means there's another disorder present. And whenever you find a high anion gap metabolic acidosis, take it one step further and calculate the delta delta ratio to uncover additional hidden metabolic processes. It's also helpful to remember that compensation has physiologic limits. The lungs and kidneys can only compensate so far. And when values fall outside those limits, it usually signals a second process. In metabolic acidosis, Expected PCO2 equals 1.5 times bicarbonate plus 8 plus minus 2. In metabolic alkalosis, expected PCO2 equals 0.7 times bicarbonate plus 21 plus minus 2. In respiratory acidosis, acute increases bicarbonate by 1 per 10. Chronic increases bicarbonate by 3.5 per 10 millimeter rise in PCO2. In respiratory alkalosis, acute decreases bicarbonate by 2 per 10. In chronic decreases bicarbonate by 5 per 10. It's also important to remember that physiologic compensation has limits. In metabolic acidosis, the PCO2 usually cannot drop below about 10. In metabolic alkalosis, the PCO2 rarely rises above about 55. And in chronic respiratory alkalosis, the bicarbonate level typically does not fall below 12. So, the big clinical pearls to keep in mind: a normal pH does not mean patient is normal. Opposing disorders can cancel each other out. Always check the anion gap. And chronic respiratory alkalosis is unique because the pH can sometimes return close to normal after renal compensation. Also, remember that early sepsis often presents first with respiratory alkalosis before metabolic acidosis develops. So, if you stay systematic and follow these steps every time, acid base interpretation becomes much more straightforward and far less intimidating. And that brings us to the end of our entire 10-part nephrology board review series. Congratulations on making it all the way through. Before we finish, let's quickly reinforce the biggest takeaways from this final section. For chronic respiratory disorders, remember that compensation depends on timing. In respiratory acidosis, bicarbonate rises slightly in acute settings, but rises much more with chronic adaptation. In chronic alkalosis, in respiratory alkalosis, bicarbonate falls, and with chronic compensation, the pH can sometimes even return to normal. Also, remember early sepsis often presents first with respiratory alkalosis before metabolic abnormalities develop. It's also important to remember that physiologic compensation has limits. Lungs and kidneys can only adjust so much, and values beyond those limits usually indicate additional mixed disorder. Winter's formula remains one of your most important tools whenever you see metabolic acidosis. It helps you quickly determine whether the respiratory response is appropriate or if another process is hiding. Mixed acid base disorders are extremely common, and one of the biggest clues is a normal pH with abnormal bicarbonate and carbon dioxide values. When that happens, always slow down and look for multiple processes occurring at the same time. And finally, always stick to a systematic approach. Start with pH, identify the primary disorder, calculate the anion gap, check compensation, and then calculate delta delta when a high anion gap is present. Following this sequence makes even complex cases much easier to interpret. Thank you for following along through this entire series. You now have a strong foundation in electrolyte and acid base physiology. Wishing you the very best with your board preparation and your clinical practice.